This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to our podcast on how to treat prostate cancer and protect your heart at the same time. And with me today, I have a good friend of mine, Michael Bivins, who's a urologist at Urology Centers of Alabama. We have also Mollie deShazo, who is an oncologist, medical oncologist, also at the Urology Centers of Alabama. And of course, Dr. Carrie Lenneman, who's director of Cardio-Oncology program at the University of Alabama at Birmingham. And then there's me, who has a prostate and have some concern, about the state of prostate cancer. So hopefully we can talk about it. So welcome on this beautiful Sunday. Thank you very much for agreeing to do this, Mike and Mollie and Carrie. We'll try to discuss, briefly during this podcast today. We'll discuss about the problem with prostate cancer. Mike is going to help us also talk a little bit about the PSA. What does it mean, and when do we need to be concerned? We'll discuss what is a localized prostate cancer. We'll talk a little bit about the treatment, which is the mainstay of treatment of prostate cancer, which is the androgen deprivation therapy, or ADT. Finally, talk about the advanced prostate cancer, and we'll finish up with Carrie and discuss maybe some of the side effects of the cardiovascular risk in patients that we treat with prostate cancer. So, and welcome, Carrie, who just joined us. Thank you for being here today in between softball games and soccer practice and whatever goes on Sunday afternoon. Thank you for being here. Mike, let's get started. And, it seems like, if you're a guy, if you don't die from the heart, the prostate is going to get you. Tell us a little bit about the prostate cancer, and it seems to be a growing problem.
Well, I think, first of all, to take a step back and say, what is the prostate? The prostate gland is a gland that only men have, and it sits in the pelvis. And the whole purpose of the prostate is a fertility organ. So if a man did not have a prostate, he could not fertilize. And so, and that's the whole purpose of the prostate gland. We know that as men get older, the gland can grow, and it can cause symptoms, and more was just symptoms, obstructive symptoms. But, there are a certain subset of populations that are prone to prostate cancer. And so as we look at prostate cancer, to really, really understand where we are today, we really have to understand where we came from. And if we look at, we'll take a stroll back, 30, 40 years, when you look at prior to 1978, 1980, the vast majority, we didn't have any great screening tools. And we know that in all cancers, and Mollie probably can attest to that survival is definitely linked to good screening protocols. And so what we found was that you had a significant number of men that were advanced stage at diagnosis. And they're 5-year, and actually, if you look at prostate cancer is really unique in that typical cancers, as you measure them, they're typically measured on 5-year survivals. Well, today, prostate cancer now is measured on a 15-year survival. But if you go back 30 years, it was also measured on a 5-year survival. So if you look at prior to 1980, the 5-year survival was 78, 80%. Reason for that is because you didn't have great screening tools. And so men were showing up when they had symptoms. And we all know that if you wait on symptoms in prostate cancer, then it's going to be more advanced. Then around in the mid 1980s, there's this little test that came about called the PSA. And that was a game changer. And so you saw the survival curves just totally shift. Men were being screened, cancers were being found early. And so you took that 78, 80% 5-year survival, and it went to 98, almost 100%. And so what a PSA is, it's a chemical made by the prostate gland, and it should be in a certain range. And when it goes above that range, and we'll talk about that range. Intentionally, I didn't tell you what that range was at this point. But when it goes above that range, then it's like an alarm going off in a house. You need to figure out what's going on at that point. And then as you stroll through the history, around 2012, the United States Preventive Task Force came out and said, wow, they addressed screening in prostate cancer. And again, the game was changed because they came out against screening for prostate cancer, screening using the PSA screening test for prostate cancer. And it had a huge effect because what happened was you start looking at family medicine practices and associations. You look at internal medicine practice association and associations. Basically, they stopped screening. And so what you start to see that curve start to shift back. We saw that. And since then, what we realized, what we had to do was in order to come up with better screening mechanisms. And it's reflected in most of the different associations, whether it's American Cancer Association, whether it's American Urology Association, and most of the verbiage that comes out now says shared decision making. So that's sort of kind of the historical, sort of journey that we've taken with PSA. When you look at the PSA, people always ask, well, what is a normal PSA? And I think that, again, that's a little bit of a complex question, but typically we like to see it in a certain range. We know that the chances of cancer, your chance of diagnosing cancer increases as the PSA increase. So historically, that number has been 4. And then there was some data that suggests that in certain populations, typically your risk of cancer may be, you'll find cancers or in certain populations that cancer risk can be higher in PSAs less than 4. And I think if you just take 4 and from 4 to 10, and I've seen several papers that look at what's your risk of cancer between a PSA of 4 to 10, and I've seen it anywhere from 15 to 25%. So 4 became sort of the hallmark number. And then they studied that, and I believe it was at University of North Carolina, if I'm not mistaken. And I think they looked at it in the military that you can find in African Americans and people that have family histories that even PSAs less than 4, between 2.5 and 4, that there are a significant number of cancers that can be missed. And so that sort of kind of changed the way we sort of address PSA screenings. Here at Urology Centers, we typically, because people want to know, okay, you can give me all this data, but give me something. Help me evaluate my patients. And what we typically do is we come up with, and again, this is just Urology Centers, in trying to look at all the data and try to help different associations try to help our patients figure out when should we screen. We typically use 2.5. And what we use is 2.5 or less is normal, or 2.5 or greater is considered abnormal. And again, I think you got to take into account a lot of different things, family history, what have you. And so the second question is, when do you start screening? And so traditionally, historically, that's been a man age 50. But again, when subsets of populations are looked at, when you start looking at patients that have, family histories, maybe genetically linked cancers, or when you look at different populations such as African Americans, in those patients, we found that even in men less than 50, you can miss a significant number of cancers. So typically we use age 40 for those people at higher risk. And we know those people are higher risk. When you take African Americans, they're 2 times the risk. When you take people with family history, they can be up to 3 times the risk of cancer. So to summarize all of that, PSA, we do believe in PSA as a screening tool. We know that it's effective in saving lives. We use a PSA of 4 or greater, unless you're at higher risk. And typically, when men that are higher risk, we use 2.5, and we start screening those men at high risk at the age of 40.
Well, that's a pretty good introduction right there, Mike. So let's say, for example, I'm 60 years old and I have a PSA that turns out at 6, and I go see the urologist. I'm referred to you. What happens after that? I mean, we're trying to decide. Is this inflammation, or is this cancer? What are the steps that you take there?
Great question. So the first thing I'm going to do is take a good history. If you have any signs and symptoms of inflammation, then I would typically say, well, let's just try to treat you with some antibiotics, try to tease out their prostatitis and then repeat it. Men that show up, I typically would probably repeat that PSA anyway, and then confirm that it's elevated before I take them down a biopsy. Again, get a good detailed history. Something as simple as we know, and it's amazing. Some people would have intercourse, before they come in and get that PSA test or the night before. Then I would tell them that once you come back in a week or 2, let's repeat it. because we know that can affect the PSA. But let's just assume all that is teased out. Let's assume that this 6 is real. Let's assume that I repeat the PSA is still elevated. Then what are the next steps? And so historically, the next steps would be, well, we'll just proceed with the biopsy. And what a biopsy is, we're trying to sample the prostate to see if there's cancer present. And the other thing that you can find out is, a lot of times you also can see if inflammation is on the tissue, then that will certainly help put you at ease as to this could be the driver of an elevated PSA. Now, more recently, we've started utilizing MRIs to get a better picture of the architecture of the prostate. To try to assess, are there lesions that are concerning when we look at them? And, historically, insurance companies did not pay for screening MRIs. But more recently, they are starting to pay for those. So there's certainly that is going into the entire screening process, being able to utilize MRIs. But again, it still makes us all feel better when we get tissue to be able to rule in or rule out if cancer is present. So even with a MRI, it may guide you as to where you need to focus on during your biopsy, but it doesn't rule out a biopsy. So if you have a true elevated PSA, as you just stated, with a gentleman that's 60, 65 years old and his PSA is 6, then that person, if it's confirmed to be that, then that person is going to need a biopsy.
So let's say, for example, you repeat the PSA, my God, it's 10. And, a physical exam was okay. You get an MRI that is abnormal. You do the biopsy and it's positive. How do you determine, okay, we're dealing with prostate cancer and you're trying to determine, how do you determine whether it's localized or what do you call localized prostate cancer? What do you call more advanced prostate cancer? And then we can talk about treatment and maybe try to bring Mollie along, maybe.
Okay. And so, Mollie, she probably is definitely, she's an expert in prostate cancer, and her area is probably a little bit more advanced prostate cancer. Typically, urologists will deal with more of the localized. And again, localized, defining that is cancer that's confirmed to be in the prostate gland and not spread outside the prostate gland. And so let's assume PSA is elevated. We do a biopsy. Biopsy comes back and the patient has cancer. Well, I think, from taking a detailed history, what if a patient comes in and he has 5 brothers that have cancer, right? Or if he has a father and the grandfather has prostate cancer, there's some genetic link to that prostate cancer. And those typically can be more aggressive, right? And so probably that patient is probably going to show up earlier. And we know that when cancer shows up earlier, they're typically more aggressive. My thought process is probably going to be this patient needs a treatment outside of active surveillance. So that's one thing. So detailed history. We will likely, assuming again you've done an exam, the prostate feels normal. We call that as a clinical T1C, which means it's localized to the prostate gland. Assuming all that's normal, at that point, MRI. The MRI is tough in this space because you've already done a biopsy. So if you've already done a biopsy and you don't have an MRI, then getting an MRI at this point is going to be not useful because it's going to have so much inflammation from the biopsy. You probably can't get an MRI for 6 months. But if you have an MRI that you got prior to the biopsy, then that may be useful because that can help determine whether this cancer is localized or not, or are there significant aggressive lesions on the MRI. The other thing that we can do to help us is genetic testing. We have multiple genetic platforms that will assess risk based off of the type of genes and the type of genetic pathways. So, if we have one of the genetic testing that shows that this patient is at high risk for, if left untreated, or if this patient is at high risk for spread, this patient is at high risk of death, then likely not treating this patient would be a good idea, or active surveillance probably would not be a good idea in this patient. However, if this patient has genes that are consistent with indolent cancers, then active surveillance would be, a good option for this patient. And, interesting, we just did a review of all our patients with localized treatment. And actually, we have more patients now in urology centers that are actually on active surveillance. I wouldn't have thought that, but we actually do. And again, the genetic testing, the genetic scoring is key. It's part of that process where we evaluate patients. But let's say that, you do all of that, you got a patient, and you still could have, and then you still can have a patient that have low genetic scores and they have low grade, and the grade tells you how it looks. It's what a pathologist looks at it, and you grade the architect of that cancer. And when you do that, that tells you how aggressive that cancer is. And typically, historically, we use what we call a Gleason score. And to not get too in detail on the Gleason score, but it gives us a pathway to tell just, again, how aggressive it is. And when I talk to my patients, I typically say the combined score between 5 and 10, where 5s and 6 are low grade, slow growing cancers, whether it's 9s and 10s are aggressive. And these are the ones that are going to spread and become a problem, and then everything in between. And you can have a patient that has low grade, the genetic score is low, and you got to take into account some patients, and you can even suggest active surveillance. You can have only one core, small amount of cancer, and I know this cancer likely won't be a problem for this patient over his entire life. And they're looking at it and say, "Doc, I still got cancer, right?" I'm like, "Yes." Well, I can't live knowing I got cancer inside of me. And so that in and of itself, even though you recommend that, this cancer will not be a problem over time, you still have to take that into account because it's a mental aspect of them living with it. But let's say that you got, a genetic score that's a little bit higher, or you got a patient with a higher Gleason score, higher PSA, and that's another thing. So risk stratifying on PSA when you evaluate is you have low, medium, and high risk. So PSA less than 10 is low risk. PSA between 10 and 20 is intermediate risk, and PSA greater than 20 is high risk. So those patients that are intermediate and high risk, they probably need a little bit more aggressive treatment plan, i.e. probably active surveillance is likely not the best option for them. And then you can consider treatments such as surgery and robotic prostatectomies. I don't think many people in the country are still doing open prostates, but if they are, fine, a prostatectomy or radiation. And I would tell you, radiation is it continues to get better and better, more precise, whether you're talking, intermediate, you're talking IMRT, or you're talking proton beam, or you're talking whatever form of radiation you're talking, they're all good options. Brachytherapy, where you place Cs, and in some instances, patients that get combination brachytherapy, which is C therapy, and IMRT or proton beam. There are other options such as cryotherapy. You got HIFU, which is high intensity focal ultrasound, as an option. And so, we go through all of these options with the patient, and we try to come up with the best option as far as treatment.
So, Mollie, now I've got this localized cancer. I've got some high risk, and you want to do. I'm concerned about the cancer in there, and particularly if cancer may be possibly growing and metastasizing. So, how do you? Even though it's a localized cancer, I'm at increased risk. What do you recommend to the patient? I mean, what are the options? I mean, Mike has mentioned prostatectomy, has mentioned radiation. Are there medical castration method as well?
So definitely, when the patients get to me, they don't come to me. First of all, thanks so much for having me on this podcast. I'm really excited to be here. It's probably not as entertaining as my favorite podcast, Smart List, but our language was probably cleaner than that podcast. But when Mike calls me, when I'm getting involved, it's not an early stage prostate cancer. So early stage prostate cancer, like he has said, is treated by either surgery or radiation. They pull me in when you have more what we call locally advanced, a bigger prostate cancer, or a prostate cancer that is the margins are a little bit hazy. Either the surgery didn't go as we hoped, which is usually when there's a surprise when they get in there and there's more disease that all of our imaging told us before the surgery. Or there's a lymph node that looked negative and, we get in there and it's positive. And that can happen even in the best surgery's hands. Our imaging is only so good. So he pulls me in if the tumor is worse than what they thought, or it was what they thought, but they thought they had to get it out anyway because a man was having a lot of symptoms from his prostate, meaning symptoms they often have is obstruction, they're having problems peeing, they're having pain. So the guys I see have a little bit more advanced prostate cancer, or they have nodes that were positive. Or in some cases, they have patients that Mike saw, and unfortunately, from the get-go, they knew that the cancer was already in the bones or had already spread. So I see either locally advanced, so, the ones who are in the lymph nodes, or people who are metastatic, which is a fancy word for saying it had spread outside outside the prostate. So for the locally advanced cancers, the therapy has changed a lot, even in the last 5 years. So we have some fairly blunt instruments for use in oncology that are old and we've been using for years. And we have some much fancier and newer technology that I think is going to change the landscape of prostate cancer, probably even in the next 5 years. How I treat prostate cancer is drastically different than how I treated it 5 years ago, and way different than how I treated it when I was trained 20 years ago. So when patients come to me, what drives most prostate cancers, what drives them is testosterone. And testosterone is actually a friend for for bodies as they age, for women and men. People don't realize that women have testosterone too. It protects our bones, it protects our heart. And I think Carrie will get into that a little bit more. But what drives prostate cancer is testosterone. So the first very blunt instrument I have is to take away testosterone. If I take away testosterone in most men, that's going to slow the progression of disease. The data is very good for that. Lowering testosterone makes people live longer. So that's what we do. We can do it by shots or pills. There's pills now that block testosterone. There's shots that have been around for decades that block testosterone. What has changed in the landscape of prostate cancer, and not to get too much into it because it's a little bit complicated and could have a whole hour podcast on itself, but is that we used to just do, we would start testosterone blockade and do that for a while. And then eventually the prostate cancer cells are smart and they're like, oh, I don't care that you're taking away my testosterone. I'm going to grow anyway. So then we would add on another different type of testosterone blockade, which we call now novel androgen blockade, not novel androgen receptor blockade. We would do that for a year. And then the prostate cancer is like, I figured that out too. And I'm going to keep growing whether you did this new fancy therapy or not. Then we would use chemotherapy, and that would work for a period of less than a year, and then patients would die. And so that progression could last anywhere from, starting the testosterone blockade, doing the fancy testosterone blockade, then doing the chemotherapy. That could last from 2 years to 20 years between where you started at point A to point C and then death, unfortunately. Now we have moved all those therapies, like most oncology, up to the front, where we hit the cancer with everything up front. And people do much better, just kind of like antibiotic resistance, that if you use multiple antibiotics at the front, you have less resistance. We're realizing that the cancer cannot get as smart as quickly if we hit them from all angles up front. So we call either that doublet therapy or triplet therapy, whether or not we use chemotherapy up front. The problem is, which Carrie will talk about, is taking away someone's testosterone has risk. The risk that the men don't like is hot flashes, essentially turning them into a menopausal woman, which no one wants to be ever. So they'll have hot flashes, fatigue, bone, increased risk of osteoporosis. It's of the stuff as an oncologist, I do tend to be in the worst. They've been the easiest. It's about a 3 or 4, but I'm not a man and I haven't had my testosterone taken away. So I don't know how that feels. They don't like it, but it works. When we add on these other therapies, we increase toxicity. So novel androgen blockade increases the risk of cardiovascular side effects and all the side effects I just mentioned. So it's a numbers game as an oncologist. Like Mike was saying, I have these blunt instruments and I have these fancy instruments and genomics, which we're not going to go into, which he was talking about, these hereditary things that help, that I can direct therapy to, that we test from the blood. That's going to change the landscape. That's what's going to happen in the next 5 years. We're going to be much more directed in therapy, depending on treating Mike's cancer instead of just all men who have the cancer the same. We're not totally there yet. We're getting there. But my instruments are better, but they're still very blunt, in my opinion, at this point.
So Mollie, if I have an advanced prostate cancer and you remove the prostate and you hit me with the triplets therapy, what's my chance of survival in the next 10 years?
So advanced has different connotations. So locally advanced, you can live, at least a decade. If you have metastatic disease, meaning cancer outside the prostate, then survival, when we used to do that, I'm talking about a decade ago, was 3 to 4 years. Now we're 4 to 5 years. Now we're 5 to 6 years, and that's median survival. So there are men who have advanced, not just locally advanced prostate cancer, who can live a decade. I mean, the curve continues to shift, and even men who are what we used to say covered up with cancer can still live years when they walk in the door with me, which was not possible a decade ago. I would say, 2 to 3 years if you were covered up with cancer everywhere, liver disease, bone disease. That was a hope, and now that is a reasonable expectation at this point.
Well, I'd like to engage Carrie now a little bit and talk, maybe expand a little bit on these side effects of the androgen deprivation therapy, and particularly when it concerns, a cardiovascular, patient. I have a lot of patients with prostate cancer. Is your treatment or your approach the same in someone who's had bypass surgery, previous, myocardial infarction or heart failure?
Alan, thank you so much for having me. But again, I think sort of like we were saying, I think prostate cancer definitely has evolved and changed in the sense that patients are living longer. So we do need to think about their cardiovascular risk and health going forward. Because as Mollie was alluding to, we take someone's testosterone away and major things happen. And from a cardiometabolic standpoint, major things happen. They have glucose intolerance, they get central adiposity, they can get sarcopenias and muscle atrophy. So you see a whole sort of landscape change as far as the metabolic parameters that are occurring in individuals. So when you have a patient that's got underlying cardiovascular risk, if those risk factors are not well controlled, or they've had a recent, MI or recent bypass, you may want to be just very aggressive at engaging the patient to be very aware of, really good glucose control, blood pressure control, make sure their medicines are really well optimized. Of course, making sure they're on a statin to help sort of calm down the inflammation and help their lipid profile. And engage them to let them know too about exercise and how important that is to help mitigate their cardiovascular risk. And then obviously in a very high risk patient, there are, like Mollie was saying, there are a lot of new tools that are out. And we think some of the older tools, the gonadotropin release hormone agonists, the like Leuprolide, that probably, if there's a way to maybe move away from that one and look at some of the newer gonadotropin releasing hormone antagonists like Degarolix or Relagolix, mouthfuls. Those actually have, the current data shows they may have a little better cardiovascular risk profile than compared to some of the older agents. So sometimes we'll have a discussion and we'll have a dialogue if someone is very high risk, especially if someone's had a recent MI or a recent bypass in the last few months, and we're really worried about their aggressive cancer, and we need to go ahead and get them on therapy and don't have a window of time. Those agents may be more favorable from a cardiometabolic standpoint. And then, also we do know that enzalutamide, which is an androgen receptor blockade, and then abiraterone, the androgen synthase inhibitor, those two can cause some fluid retention and hypertension. So if I have a patient that's going to be started on those agents, again, I really just sort of engage them about education, about saying, hey, I want you to start looking for swelling, fluid. I want you to weigh yourself. Let me know if you're having fluid or swelling, so we might need to start you on a diuretic. And we know that the hypertension is well associated with these two agents as well. So again, I just sort of engage them, empower them to be checking their blood pressures at home. And we know the hypertension that occurs with those two agents are actually independent of steroid use. I mean, we think steroids cause some of it, but it's actually, studies have shown that it's actually independent of steroids itself, because steroids are often used with those agents.
I have a patient that we've been treating for, his hypertension, and he had hypercholesterolemia. He ended up with prostate cancer, treated with Leuprolide or Lupron. And, is concerned that, 5 years into this, we're trying to kind of control his blood pressure, trying to control his cholesterol, that we're seeing some progression, on the CT, for example, there's more calcium developing. What do we have studies actually kind of, looking at this, what is the best way to treat a, cardiovascular patient who end up with the prostate cancer?
Yeah, I don't know that there are actually prospective studies that show that, especially on sort of older therapies like Lupron, how medical therapy mitigates risk, although we know it probably does. But if it's already known and we see it progressing, I guess that might be a time to maybe talk with their medical oncology team to say, do we have other agents that we think could be potentially used? Because I'm seeing calcium progression in their aorta, or I'm seeing calcium progression in their CTs that they're getting, if that is a concern. And if they're on optimal medicines, high dose, high intensity statin, and their blood pressure is well controlled and their glycemic index is well controlled, I think it's hard to know. And again, from a cardiovascular standpoint, there are newer agents like SGLT2 inhibitors and things like that. We don't really know what that would do in a prostate cancer patient, with someone who has underlying heart failure or underlying coronary disease. So hopefully as we are adding newer, more novel agents to our cardiovascular profile for our patients, we're hoping that it'll improve their outcomes.
This is when it becomes so crucial for us to interact with our cardiologists. Carrie and I know each other from UAB. When I was there, more and more we're discussing, having regular cardiology referrals for these patients. To be honest, it didn't matter 10 years ago, even 15 years ago, because they would die of their prostate cancer. And so these were not issues that were on our brains. And now that people are living decades with advanced prostate cancer, we have to start weighing the pros of, am I going to kill them from what I'm doing to them, or is the cancer going to kill them? And that's a really hard way to think about it. But once again, we have very blunt instruments and we have to use them very carefully. So, when a patient comes to me and they have horrible diabetes and they just had an MI and they have prostate cancer, what's going to really take their life? Is it going to be their horrible uncontrolled cardiovascular disease and their diabetes, or is it going to be their prostate cancer? I don't want to make their diabetes and heart disease worse and cause that to be the end of their life. Sometimes the prostate cancer has to take a back seat and get their other cardiovascular disease under control first before I start making it worse with what I'm going to do to them. So, interdisciplinary care of these patients is becoming more and more relevant. I don't know half the drugs that Carrie talks about anymore, these new antihypertensives and stuff. And I can't be expected to know all these. That's why I need her and I need cardiologists to help me navigate this. And knowing the drug interactions with the drugs that all these drugs are metabolized in different ways. And so the cardiovascular medicines are metabolized in different ways. And if we don't coordinate care, then we may be, shooting ourselves in the foot, thinking I'm actually treating something and the medicine she's giving is making my drug metabolize in a way that it's not helpful. So this is getting, as all medicine getting more and more super specialized, here we are again of very complicated drugs and their interactions with each other.
Well, it seems like when you have a patient with prostate cancer, the prevention methods are, of prime importance and working on their blood pressure, their cholesterol, their diet, exercise. Mike?
Yeah, I got a quick question. So we now, when you start looking at costs with these drugs that we have, they can be very costly and copays can be very costly. And we've seen a trend where patients are opting more for orchiectomies. And so, Carrie, one question I would have is, where does orchiectomies fall on that cardiac risk?
Yeah, sure, Mike. I mean, I don't know there are grounded in a whole lot of studies when we do an orchiectomy to help basically blunt the testosterone production. But in general, we still know that those cardiometabolic profiles change, that, when you rapidly remove an organ that helps produce testosterones, that we do see patients end up having glucose intolerance. They develop, unfortunately, as Mollie mentioned, the hot flashes, all the other kind of acute kind of menopausal type symptoms. And then obviously they have like the central adiposity, weight gain, those typical things, which are really hard and challenging for individuals. So I think usually, unfortunately, patients don't come to me. They usually come to me saying, can this person undergo an orchiectomy? They don't really say, orchiectomy versus ADT for patients, or I haven't yet had that experience, but I guess that could be a potential for some individuals, especially if they, maybe for whatever reason, their insurance won't approve the other ADTs that are more cardiovascular favorable than others. That might be an option.
Well, I see a lot of patients that when you look and you say, well, a 3-month Lupron shot is going to be $200 every time. And that's significant to them. And then the conversation or Govics may be, $100 a month. And then they're like, well, you know what? Do you have anything else cheaper? Because with gas prices going up and food prices going up, that's significant. And whereas, you could do a one-shot pop, no pun intended, and handle the ADT, ablation portion with the procedure. I am getting people that are opting for that. And I can do an orchiectomy, leave the epididymis. And for these guys that's mentally like, I don't have anything in my scrotum, they can still feel something in their scrotum and they're opting for that. And so, I just didn't know where the cardiovascular, if I'm lining that up, is that something of counseling, something that I need to also think about in addition to just counseling on ADT treatment.
I think it's great. I do think that we do know that their cardiometabolic profile will change with that. And then just, again, maybe having them engaged with their primary care team or their cardiologist, they're seeing one, just say, hey, when we do this, just like as if we did ADT, we know that these things will change. We just want to make sure you're plugged in and that that you're getting, follow-up care, because we're really working hard to give you longevity and good life expectancy for your prostate cancer. But we want to make sure that we're not, turning you into a horribly controlled diabetic or someone who's going to be crippled by heart disease. But I think that's a great point, Mike. I honestly don't get patients really at that decision point, but I think where you're coming from your viewpoint, that's very, very valid. And I could see that as a good option.
I mean, we haven't discussed much the quality of life of these patients and all the stuff we do to them. This is not, it's not fun what they're going through here. And Mike touched on the mental aspect of just feeling something in your scrotum. I had a professional football player who the weight gain just undid him. He was a big muscular guy his whole life, part of his identity. He played professional football and he gets sarcopenia, muscle wasting, breast growth. And, became clinically depressed from everything we were doing. And at some point we just had to pull back because he just could not live like that. And he didn't want to live like that. So it's hard work that these men do to be around. And I think sometimes it's negated because men just don't complain a lot of times about all the horrible things we're doing to them. And we need to really be careful about asking them.
And that's a great point too, is that, you could have a podcast on the mental aspects of prostate cancer and prostate cancer treatment.
Absolutely. Where do you think we're going to be 5 years from now? Where's the research, going?
Well, with medical oncology, it's amazing. I think we do genomics now. So we're testing for what we call homologous recombination repair problems. So genetic defects where that we can target with drugs. So breast cancer research has a lot of the same things. So you hear of the BRCA mutation that Angelina Jolie had, and she had, these are people who have hereditary breast and ovarian cancers. We were a little late to the game in prostate cancer, understanding that there is a significant portion of men who have these HRR mutations who we can direct care with a lot of the same drugs that we're using for breast cancer treatment for men with prostate cancer treatment. So already in the last, year and a half with new data that I talked about of this doublet and triplet therapy using all of our drugs up front, like we discussed earlier, I think in, a year or two, maybe even 3, there's multiple trials that are using drugs to target these HRR mutations that are much fancier and makes much more sense. And other mutations we're finding that are common, and there's drugs in development to target more specifically. So hopefully our therapy will be less and less blunt as we go forward.
I think that, it is something that's just kind of, high on my radar is personalized medicine. It's figuring out how to address things on an individual basis. And I think genetics and genomics are central to that, as Mollie stated. And I think that as the things that we have now, we keep moving them forward. We keep moving them. Anytime you introduce a new therapy, they're actually introduced at the most advanced stages. But I think then you continue to move them forward. So we'll continue to move some of these, novel therapies forward. I think we'll figure out who needs to be screened. We'll figure out who needs to be screened, who needs to be treated. We'll get better imaging. We'll get better genomics to understand cancer better. I mean, even though we have what we have today, we're still the tip of the iceberg on understanding the genomics. And I think that's where this personalized medicine, that's where things will go. We'll get better technology on taking out, and operating and radiation. We'll get better radiotherapies or targeted therapies, if you will. And we'll get better focal therapies, whereas you don't really have to basically remove the whole prostate, radiate the whole prostate, ultrasound the whole prostate. So I think we'll be able to go there. I think, immunotherapies will probably continue to move forward. And, I always, I was talking to my partner, Dr. Bug, and I was talking about it. I just asked him, I said, man, if you got diagnosed with prostate cancer, would you just pay for immunotherapy up front? And we both said, yeah, we probably would. We'd just go ahead and get the programs up front. Now, there's no studies on that, but I think it makes sense. And I think you'll start to see things continue to move forward earlier on in the disease. Interesting time. And I do agree with Mollie. We are totally treating prostate cancer different than we did 5 years ago, but certainly 10, 20 years ago. And it's still evolving. So we'll see.
Well, maybe we're not going to die anymore, either from the heart or for the prostate. Yeah. How to treat prostate cancer and protect your heart. Thank you very much, guys. Mike Bivins, Mollie deShazo, Carrie Lenneman. Always a pleasure to get together, and particularly on a beautiful Sunday afternoon. Enjoy.
Thank you so much for having us.
Thank you. Thank you for having us.
Thank you. All right. Take care.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.